the silent disease millions don't feel, your doctor calls with your lab results. You're expecting nothing, you feel fine. You felt fine for years. No dizziness, no strange symptoms, no reason to think anything is wrong. And then she reads you a number, and everything shifts. This is called undiagnosed diabetes. It's a condition where blood sugar has been elevated, silently, for months or years, doing damage the whole time without a single warning sign you could feel. Here's what's actually happening. When blood sugar runs chronically high, glucose molecules begin chemically bonding to proteins in your blood vessel walls, in your nerve sheaths, in your eyes. It's not a dramatic process, it's quiet, molecular, the kind of destruction that takes years to become visible, and by then, it's already been going on for a very long time. What makes it different from most diseases is that it doesn't make you feel sick while it's progressing. A broken bone tells you immediately. An infection announces itself with fever. Diabetes can silently strip the function from your kidneys, your eyes, and the nerves in your feet while you're living your normal life, going to work, sleeping fine, feeling nothing unusual at all. And here's the twist. The degree of damage accumulating has very little to do with how you feel in the moment. Someone who feels completely healthy can be building toward blindness. Someone who feels vaguely tired can have blood sugar that's only mildly off. The symptom doesn't match the scale of what's happening underneath. There is, however, one thing that changes everything about this disease. It is extraordinarily manageable, more controllable than most chronic conditions. And some people lower their blood sugar dramatically without any medication changes at all. This video covers exactly how. Every major method, in order from monitoring to medication to things most people never consider. The body's relationship with sugar is more complicated than it sounds. What diabetes actually is. You wake up every morning running. Not jogging, running metabolically. Every cell in your body needs fuel to operate. Your brain, your heart muscle, the neurons firing right now as you read this sentence. That fuel, almost universally, is glucose. Glucose is the body's primary energy currency. It comes from the food you eat, floods the bloodstream after a meal, and needs to get inside your cells to actually be used. And this is where the problem begins. Because glucose can't get in on its own. It needs a key. That key is insulin. It's a hormone produced in the pancreas, and its one essential job is to bind to receptors on your cells and open a door. Technically, it triggers the movement of transporter proteins called GT4 to the cell surface, which pull glucose in from the blood. Without that insulin signal, glucose stays outside, circling in the bloodstream with nowhere to go. Diabetes occurs when this system breaks down. Either insulin is gone entirely, or there isn't enough of it, or the cells have stopped responding to it correctly. What makes it different from simple high blood sugar as a symptom is the mechanism. The glucose isn't elevated because you just ate a cake. It's elevated because the biological infrastructure that clears it is compromised. The transporter system is failing, and depending on why it's failing, the whole approach to fixing it changes completely. And there's a cruel downstream consequence that most people don't think about. When glucose can't get inside cells, cells start going hungry. The body interprets this as starvation even when plenty of glucose is available. So it breaks down fat and muscle for fuel, triggering a whole cascade of secondary effects. High blood sugar and starving cells at the same time. That paradox is diabetes. The question is, why does the system break down in such completely different ways in different people? The different types of diabetes. You could have two people sitting in the same waiting room, both diagnosed with diabetes, both managing their blood sugar, and the reason their bodies can't handle glucose may have almost nothing in common. This is called phenotypic diversity, and it's one of the most important things to understand before any other conversation about control. Type 1 diabetes is an autoimmune condition. The immune system misidentifies the insulin-producing beta cells in the pancreas as foreign and destroys them. No beta cells, no insulin production. People with type 1 require exogenous insulin from the moment of diagnosis and for the rest of their lives. It isn't caused by diet, lifestyle, or weight. It's the immune system attacking itself, often beginning in childhood but increasingly diagnosed in adults. Type 2 diabetes is a completely different disease. Here, the pancreas still produces insulin, but the body's cells have become progressively resistant to its signal. The pancreas compensates by producing more and more, until eventually it can't keep up with the demand and blood sugar begins to rise. It develops over years, is strongly associated with excess visceral fat, and critically, is often reversible. Gestational diabetes occurs during pregnancy, when placental hormones create a temporary but significant state of insulin resistance. If left unmanaged, it carries real risks for both mother and baby. Prediabetes is an intermediate state. Blood sugar elevated but not yet at diagnostic thresholds. Affecting hundreds of millions of people globally who don't know they have it, there are rarer forms that are often misdiagnosed. LADA, sometimes called type 1.5, is a slow-progressing autoimmune form that appears in adults and mimics type 2. MODY is a genetic mutation in beta cell function that often responds dramatically to simple oral medication. Type 3C arises from direct physical damage to the pancreas. The reason this taxonomy matters is direct. How you control diabetes depends entirely on which type you have, understanding blood sugar numbers. A diagnosis comes with numbers. Most people learn one or two of them and think that's enough. It usually isn't. The first is fasting plasma glucose, blood sugar measured after at least 8 hours without food. It tells you your baseline, how well your liver is regulating overnight glucose release. Normal is below 100 milligrams DDL. Above 126 confirms diabetes. The second is post-meal glucose, usually measured 2 hours after eating. This reflects how efficiently your body handles an actual carbohydrate load. Normal is below 140. At or above 200, combined with symptoms, it's diagnostic. The third is HbA1c, glycated hemoglobin. This is the one most people have heard of, and it works differently. When blood sugar is elevated, glucose molecules chemically bond to hemoglobin proteins inside red blood cells. Since those cells live about 3 months, the percentage that have been glycated gives you an average of blood sugar control over that period. Below 5.7% is normal. At or above 6.5% is diabetes. The fourth metric, and the one that modern care is increasingly built around, is time in range. This comes from continuous glucose monitors and tracks what percentage of your day you spend in the target zone of 70 to 180 milligrams DL. The goal is above 70% for most adults. Here's the critical insight about why trends matter more than single readings. HbA1c gives you an average. But a 7% HbA1c could mean your sugar is stable around 154 milligrams DDL all day, or it could mean you're swinging between 40 and 280 on the same average. The average looks the same. The damage profile is completely different. And here's the problem that single readings will never reveal. Blood sugar can look normal at the moment you test it, while catastrophic spikes are happening between your meals. Every day, doing damage you'll feel years from now. The first control method: knowing your numbers. There's a straightforward reason why monitoring comes first, before diet, before medication, before any other intervention. You cannot make good decisions about a variable you're not measuring. This is called self-monitoring, and it exists at 2 levels. Traditional fingerstick testing gives you a snapshot, a single glucose reading at the exact moment you test. The number is precise and real. The problem is it's also a single frame from a continuous film, and the film has a lot happening between shots. You miss what your blood sugar did between meals, how it behaved overnight, whether it spiked after specific foods and then crashed. Continuous glucose monitors change this completely. A CGM is a small sensor worn on the skin, usually the arm or abdomen, with a tiny filament measuring interstitial glucose every 5 minutes, all day, all night, for 10 to 14 days at a time. The data streams to a phone or display in real time. You can watch your blood sugar moving while you're eating. What this enables is pattern recognition, and it transforms how people manage the disease. You stop guessing whether rice spikes you more than pasta. You stop wondering if your morning walk is helping. You can see the line flatten after you do it. The medication question becomes answerable because you can see whether it's working, and when it's wearing off, there's a specific metric called glucose coefficient of variation, the stability of your glucose swings. A CV below 36% is the clinical threshold for what's considered well-controlled. Without continuous monitoring, you'd never know where you stand on that measure. The action here is blunt. People who monitor their glucose improve their control. People who monitor it continuously improve it more. It's not because the device does anything, it's because information changes behavior. How food raises blood sugar? Every meal is a test, not a moral one, a metabolic one. What you eat it with, and what order you eat it in will determine whether the next 2 hours look like a gentle hill on a glucose monitor or a cliff. Carbohydrates are the primary driver. They're broken down into glucose in the small intestine and absorbed directly into the bloodstream. The faster this happens, the sharper the spike, but not all carbohydrates behave the same way. A glass of apple juice and an apple have nearly identical sugar content. They behave completely differently in the body. The juice hits your bloodstream in minutes, no chewing, no structural breakdown, nothing to slow the transit. The apple comes with fiber, water, and cell wall structure that slows digestion substantially. Same sugar, different metabolic event. Fiber is the central variable. Soluble, viscous fiber, the kind in oats, legumes, psyllium, dissolves in the gut and forms a gel that physically slows enzymatic digestion and delays glucose absorption. It's not metaphorical. It's a physical mesh that intercepts glucose before it can rush into the portal vein. Fat and protein change the picture differently. They don't raise blood sugar themselves, but they trigger the release of hormones that slow gastric emptying. meaning the stomach releases its contents more slowly. A meal with fat and protein combined with carbohydrates has a gentler glucose curve than the same carbohydrates eaten alone. The food matrix matters enormously. What this means practically: the composition of your entire meal, not just the carbohydrate in it, determines the glucose response. A plain bagel eaten alone is a metabolic event. The same bagel eaten with eggs and avocado is a slower, flatter one. The next chapter covers one mistake many people make while trying to eat well. And it's not the one they expect. The biggest dietary mistakes. Here's a common scene in a clinic. Someone shows their food diary. Salads, smoothies, fruit, whole grains, brown rice, no added sugar. And their blood sugar is still a problem. Not because they're lying. Because several of these things, which genuinely look healthy, are quietly doing damage. The first mistake is liquid calories. Fruit juice, smoothies, sweetened teas, flavored waters. The problem isn't the sugar content alone. It's the delivery mechanism. When there's no solid food matrix, no fiber to slow absorption, no fat or protein to delay gastric emptying, the glucose hits the bloodstream almost immediately. An orange gives you sugar slowly. Orange juice gives you the same sugar in a metabolic sprint. The second is oversized portions of nominally healthy foods. Brown rice has a moderate glycemic index. A large portion of brown rice delivers a high glycemic load. The index is a rate. The load is the total. You can exceed safe blood sugar thresholds entirely with healthy foods if the quantities are wrong. The third mistake is the most overlooked: over-reliance on products labeled diabetic or sugar-free. Many of these are sweetened with polyols, sugar alcohols, and not all polyols are equal. Erythritol has a glycemic index of 0. Maltitol has a glycemic index of 35 to 52, can meaningfully raise blood sugar and insulin demand, and is used in the majority of sugar-free chocolates and cookies on the market. The diabetic label is not a reliable guide to glycemic safety. The hidden sugars challenge is real. Ketchup, granola, protein bars, low-fat yogurt, salad dressings, flavored oatmeal. The sugar content in processed foods is not where most people expect to find it. Reading nutrition labels for total carbohydrate and identifying specific sweetener types is a genuine metabolic skill. The mistake isn't caring. The mistake is trusting marketing rather than the label. Portion control. The overlooked weapon. There's a clinical truth that sounds obvious once stated, but isn't how most people think about food. The volume of what you eat matters as much as what it is. This is the foundation of portion control, and it's consistently underused. The plate method is the clearest clinical framework. Half the plate is non-starchy vegetables, things like leafy greens, broccoli, cucumbers, peppers. These have minimal glucose impact and substantial fiber. 1/4 is lean protein, chicken, fish, legumes, tofu. The final quarter is complex carbohydrates with fiber, like sweet potato, quinoa, or beans. Not a heaping quarter, an actual quarter. The serving awareness piece is more granular than people expect. A cup of cooked pasta is roughly a fist. A serving of rice is half a cup. Most restaurant servings are 2 to 4 of those. The calories that create a weight problem and the glucose load that drives insulin resistance often come not from particularly bad food choices, but from accurate food choices in inaccurate quantities. There's also an underappreciated finding about eating sequence that changes the math on portions. Eating fiber-rich vegetables first creates a physical barrier in the small intestine. Following with protein and fat triggers satiety hormones and further slows transit. By the time the carbohydrates at the end of the meal are being digested, the established digestive environment buffers their absorption significantly. The same meal eaten in a different order produces a measurably different glucose curve. This is why eating well isn't a binary switch. The composition, the quantity, and the sequence all compound on each other. Even the healthiest food on the planet will raise your blood sugar if you eat enough of it. Low-carb approaches explained. The most direct way to reduce glucose spikes is to eat less of the thing that causes glucose spikes. That's not a trick. It's the underlying logic of low-carbohydrate dietary approaches. Restricting carbohydrate intake to below roughly 130 grams per day reduces the raw glycemic load entering the digestive system. Fewer carbohydrates means less glucose to absorb, which means lower peaks and lower insulin demand. Clinical trials consistently demonstrate that low-carb diets lower HbA1c by approximately 0.5% more than conventional approaches in the first 3 to 6 months, with the most pronounced benefits in people with the highest baseline numbers. The mechanisms go beyond just fewer carbs. Lower insulin levels throughout the day reduce hepatic triglyceride synthesis. The liver stops turning excess sugar into fat as aggressively. Circulating triglycerides drop by 15 to 40% in most trials, and HDL cholesterol typically rises. There are real cardiovascular benefits alongside the glycemic ones. The potential limitations are worth being clear about. Carbohydrate restriction isn't inherently dangerous for most people with diabetes, but it can interact with certain medications, particularly those that lower blood sugar independently of food intake. in ways that require dose adjustments. Anyone on insulin or sulfonylureas reducing carbohydrates significantly should be doing it with clinical supervision. The sustainability concern is the central issue with the data. Adherence rates decline sharply after 12 months in most trial populations. By 2 years, the HbA1c and weight improvements of low-carb approaches tend to converge with conventional dietary approaches. Not because the mechanism stopped working, because most people stopped doing it. The diet that lowers your blood sugar is the one you actually follow. Some people achieve remarkable results using a fundamentally different strategy: Mediterranean diet and diabetes. There's a large clinical trial that ran for 5 years. It compared a Mediterranean dietary pattern against a low-fat diet in people with coronary heart disease, tracking metabolic outcomes over the long term. The Mediterranean group achieved higher and more durable rates of type 2 diabetes remission than the low-fat group. Not a small effect, a clinically meaningful one. The Mediterranean diet is built on seasonal vegetables, legumes, whole grains, nuts, extra virgin olive oil, and fish. No single food group is eliminated, no extreme restriction. The glycemic control it produces comes from the combination of high-fiber, anti-inflammatory polyphenols, and healthy fats working together, not from dramatically reducing any one macronutrient. Olive oil is a useful example of how the mechanisms work. It's rich in oleic acid, a monounsaturated fat that reduces circulating inflammatory markers. Specifically, it lowers neutrophil count. Less inflammation means more responsive insulin receptors. Better insulin sensitivity without any change in carbohydrate quantity. The fat itself is an active therapeutic element, not a neutral calorie. What makes it different from a low-carb diet isn't just the macronutrient distribution. It's the behavioral sustainability. The Mediterranean pattern doesn't require you to avoid categories of food. It prioritizes whole foods over processed ones, healthy fats over refined oils, fiber-rich vegetables over nutrient-poor starches, but within a framework that maps reasonably well onto normal social eating, normal restaurant menus, normal family meals. The clinical data on long-term adherence is substantially better than it is for highly restrictive approaches, which is why it remains one of the most recommended dietary frameworks for metabolic disease management worldwide. Consistency beats extreme restriction. Every time. Fiber, nature's blood sugar regulator. Most people think of fiber as roughage, something that keeps digestion moving. The actual metabolic role is considerably more interesting than that. Viscous, soluble fiber, the kind in oats, lentils, beans, flaxseed, and psyllium, does something specific in the intestine. It dissolves into a gel that physically slows the transit of food and the enzymatic breakdown of carbohydrates. This is the mechanism behind the blunted postprandial glucose response you get from high-fiber meals. The fiber is literally getting between the digestive enzymes and the starch, buying time. But that's the simple part. What happens in the colon is significantly more complex. Specialized gut bacteria, species like Faecalibacterium prausnitzi and Roseburia intestinalis, ferment soluble fiber and produce short-chain fatty acids as a byproduct, primarily butyrate, propionate, and acetate. These SCFAs aren't just waste products. They bind to receptors on cells in the gut lining and trigger the release of GLP-1 and peptide Y, hormones that enhance insulin secretion, suppress glucagon, and signal satiety to the brain. Butyrate also directly reduces inflammatory signaling from fat tissue, improving peripheral insulin sensitivity. The upstream consequence of eating more fiber isn't just slower glucose absorption from that meal. It's a downstream shift in gut microbiome composition, hormone secretion patterns, and systemic inflammation, all of which improve metabolic function over time. Current recommendations call for 25 to 38 grams of fiber daily. Most people eat less than half that before continuing. How much fiber do you actually consume in a typical day? Not a rough guess. Think through yesterday's meals. Most people who run the calculation for the first time are surprised by how far short they fall. Whittle loss and insulin resistance. Insulin resistance isn't primarily a muscle problem or a liver problem. It starts in fat tissue, specifically in visceral fat that surrounds the abdominal organs. When fat cells expand beyond their capacity, they stop sequestering fatty acids cleanly. Those fatty acids start overflowing into tissues that weren't designed to store them: the liver, the pancreas, the skeletal muscle. This ectopic lipid accumulation, fat in organs that shouldn't have it, is what drives systemic insulin resistance. The fat physically interferes with insulin receptor signaling at the cellular level. Magnetic resonance imaging studies have tracked what happens when people begin losing weight. The liver fat clears first, often within the first week of calorie restriction, before significant total body fat loss is visible on a scale. And when liver fat clears, hepatic insulin resistance reverses rapidly. Fasting glucose normalizes almost immediately. The pancreatic fat takes longer to clear, but when it does, beta cell function begins recovering. This is why even modest weight loss has outsized metabolic effects. A 3 to 7% reduction in total body weight, which for a 200-pound person is just 6 to 14 pounds, can significantly reverse insulin resistance and improve HbA1c. The effect isn't proportional to total weight lost. It's driven by ectopic fat clearance, which begins early. There's also a finding that upends the common narrative about body size and diabetes. Research called the RETUNE study showed that people with a normal BMI can develop type 2 diabetes by accumulating excess ectopic fat that exceeds their personal genetic tolerance, even if they aren't obese by any external measure. Diabetes isn't caused by exceeding a population threshold. It's caused by exceeding your own. Food matters enormously. But movement changes the equation in a completely different way. Exercise. One of the most powerful treatments. When you contract a muscle, something happens that is independent of insulin entirely. Under normal conditions, insulin is what triggers GUT4 proteins, the glucose transporters, to move to the surface of muscle cells and pull glucose out of the bloodstream. Without insulin, this doesn't happen efficiently. This is the core problem in diabetes, but during physical exercise, muscle contractions activate a separate intracellular signaling pathway through a protein called AMPK that also drives UGT4 to the cell surface, completely bypassing the insulin receptor. Contracting muscles become a glucose sink that doesn't require the broken key. They pull sugar out of the blood directly, through their own mechanism. While you're moving, this happens immediately. Not after weeks of training. During and after a single session of exercise, blood sugar drops. The effect continues for hours post-exertion as muscles replenish depleted glycogen stores. And with regular training, insulin receptor sensitivity improves at the cellular level. The underlying resistance decreases, meaning insulin works better for everything else the body needs it to do. Exercise also reduces visceral fat. It lowers systemic inflammation. It improves sleep quality, which independently affects glucose control. It addresses the stress hormone cycle that elevates blood sugar between meals. The metabolic benefits compound across multiple pathways simultaneously in a way that no single medication currently matches. There's one specific type of physical activity that stands out as particularly effective for acute blood sugar control. It's not an intense gym session. Most people already do it, walking after meals. The peak glucose spike after a meal occurs roughly 45 to 60 minutes after eating. It's during this window that blood sugar climbs as the carbohydrates from the meal are digested and absorbed. For people with diabetes, this peak is sharper and lasts longer. And the amplitude of those peaks, how high they go, is one of the primary drivers of vascular damage over time. Post-meal walking directly intercepts this process. A 10 to 30-minute brisk walk, initiated within 15 to 30 minutes after a meal, uses contracting muscles to pull glucose out of the bloodstream at the exact moment it's entering it from the gut. Clinical trials consistently show this reduces peak glucose excursions by 10 to 30%. The timing is the mechanism. It's not just that you're walking, it's that you're walking when the sugar is arriving. There's a comparative finding that's worth pausing on. Research on exercise timing shows that short, scattered walking bouts, 3 10-minute walks after each meal, can outperform a single 30-minute session done at a fixed time of day, in terms of blunting postprandial glucose specifically. The aggregate exercise time is the same. The metabolic impact is different because of when it happens. The practical implementation is simple enough to be sustainable. You eat lunch, you take a 10-minute walk around the block or down the hallway before sitting back down. You don't need equipment, a gym, or even comfortable clothes you haven't ruined yet. You need to get up and move within about 20 minutes of finishing your meal. This is the quickest metabolic win in diabetes management. Immediate effect, no cost, minimal barrier to entry. You can start today after the next meal you eat. Strength training and diabetes. Aerobic exercise creates an acute metabolic event. Resistance training builds a permanent infrastructure. Skeletal muscle is the body's primary storage site for glycogen, the form of glucose that cells keep in reserve. The more skeletal muscle mass you carry, the larger the anatomical basin available to absorb and store excess glucose from the bloodstream. Every kilogram of additional muscle is additional capacity. When you resistance train, lifting weights, doing body weight exercises, any movement that makes muscle fibers work against significant load, those muscle fibers sustain microdamage, then rebuild thicker and denser. The rebuilt tissue has expanded glycogen storage capacity and a higher density of GUT4 transporters. More surface area to pull glucose in, more space to store it. The mechanism that drives this adaptation is the same AMPK pathway activated during acute exercise, but in this context, it specifically drives muscle glycogen resynthesis after resistance training. The muscle is pulling glucose out of the bloodstream to replenish what it depleted during the session and to build new tissue for next time. This process continues for 24 to 48 hours after a single strength training session. Long-term effects on insulin resistance are additive to those from aerobic exercise, but reach them through different pathways. Aerobic training improves mitochondrial density and substrate metabolism. Resistance training increases the physical reservoir for glucose disposal and the density of transport proteins at the cell surface. The combination, regular walking and regular resistance training, is consistently more effective for HbA1c reduction than either alone. Physical exertion, however, isn't the only hidden factor that controls blood sugar. The one most people are getting wrong isn't in their gym routine, still leave. The forgotten diabetes controller. One night of inadequate sleep, less than 6 hours, measurably worsens insulin sensitivity the following day. This isn't a theory. It's been demonstrated in controlled studies. And most people with poorly managed diabetes are chronically, repeatedly doing this to themselves. Here's the mechanism. Normal sleep moves through cycles of light sleep, slow-wave deep sleep, and REM sleep. The deep sleep phase is particularly important metabolically. It's when cortisol levels are lowest, when growth hormone drives cellular repair, and when the brain clears metabolic byproducts. This sleep deprivation disrupts the circadian rhythm of cortisol secretion, shifting it so that evening cortisol levels stay elevated and daytime peaks become abnormal. Cortisol is a glucocorticoid. It tells the liver to release glucose and tells cells to conserve it for the brain. Chronically elevated cortisol is a continuous mild infusion of insulin resistance. It doesn't stop there. Sleep loss increases ghrelin, the hunger hormone, and decreases leptin, the satiety hormone. You wake up more hungry and less satisfied by what you eat. Caloric intake rises. The foods craved under sleep deprivation skew toward high carbohydrate, high sugar options. The exact macronutrient profile that hits the blood sugar hardest sleep also governs the sympathetic nervous system. Poor sleep hyperactivates it, which signals the liver to release more glucose, independent of what you eat. The person who is eating well, exercising, taking their medication, but sleeping 5 hours a night is working against themselves on a mechanism they may never have been told about. You may be sabotaging your blood sugar every night and attributing the problem to something else entirely. Stress and blood sugar. There's a reason your blood sugar rises before a difficult conversation, during a work crisis, and after a bad night of arguments. Stress is not a psychological event that happens to leave physical traces. It is a biological event that directly changes your glucose levels. These are called counter-regulatory hormones, and their job in the context of evolution was to fuel physical response to threat. When your body perceives danger, psychological or physical, the hypothalamic pituitary adrenal axis activates, triggering the release of cortisol and catecholamines, primarily epinephrine and norepinephrine. Epinephrine immediately triggers glycogenolysis. The liver breaks down its glycogen stores and releases glucose into the bloodstream. Cortisol triggers gluconeogenesis. The liver synthesizes new glucose from amino acids and fats. Simultaneously, both hormones impair insulin receptor signaling in peripheral tissues, meaning the glucose they've just released into the blood can't be cleared efficiently. The original purpose of this cascade was to fuel sprinting away from something that wanted to eat you. Your blood sugar rises, your muscles have fuel, you survive. The problem is that in contemporary life, the stressor is a difficult email. The stress hormones fire exactly the same. The glucose floods the bloodstream exactly the same. And then you sit in a chair. No muscles contract. The glucose doesn't get used. And this happens multiple times a day, every day, months and years. Chronic psychological stress maintains a state of persistent mild hyperglycemia that no diet change can fully correct while the stress continues. Clinical approaches to stress management, structured breathing, physical movement as a discharge for mobilized glucose, cognitive behavioral techniques are not optional extras in diabetes management. For some people, they're the missing piece. Think back to the most stressful period in your life. What were your energy levels, your eating patterns, your sleep quality? The metabolic profile of that period was probably worse than any of the years around it. Diabetes medications explained. There is a persistent cultural narrative around diabetes medications, particularly insulin, that frames them as failures. As if the person who needed medication to manage their blood sugar did something wrong and the medication is the consequence. This framing causes real harm. People delay treatment. Blood sugar stays elevated. Damage accumulates. Medication is a clinical tool. Nothing more, nothing less. Different drug classes address different points of failure in the glucose regulation system. Metformin, typically the first-line medication for type 2 diabetes, reduces hepatic glucose production. It tells the liver to release less glucose overnight, lowering fasting levels. It doesn't cause the pancreas to produce more insulin. It doesn't create hypoglycemia risk on its own. SGLT2 inhibitors work through an entirely different mechanism. They block glucose reabsorption in the kidney's proximal tubule, causing the kidneys to excrete glucose through urine. The result is lower blood sugar, lower blood pressure, reduced visceral fat, and, importantly, strong cardioprotective and kidney protective effects that have been demonstrated in large clinical trials. These drugs protect organs, not just numbers. GLP-1 receptor agonists mimic a gut hormone that enhances insulin secretion in response to meals, suppresses glucagon, slows gastric emptying, and reduces appetite. They typically cause weight loss rather than weight gain. Major trials show significant reductions in heart attacks, strokes, and cardiovascular death. Sulfonylureas stimulate the pancreas to produce more insulin directly. Effective, inexpensive, but potentially causing weight gain and hypoglycemia with missed meals. Each class works at a different point in the system. The right choice depends on the individual's type of diabetes, kidney function, cardiovascular risk, weight, and what the primary failure mode of their glucose regulation actually is. The goal isn't to avoid medication. The goal is to control blood sugar, and medication is frequently what makes that achievable. Insulin therapy explained, insulin is not the last resort. That framing has delayed its use in millions of people who needed it far earlier than they received it. For type 1 diabetes, insulin is not optional at any stage. The beta cells that produce it are gone. Exogenous insulin is the replacement for a destroyed system, not a treatment of choice. It's a biological necessity. For type 2 diabetes, insulin becomes necessary when the pancreatic beta cells have been under chronic metabolic stress long enough that their ability to secrete insulin on demand declines significantly. This isn't a character failure. Beta cell exhaustion is a physiological consequence of prolonged hyperglycemia, and addressing it with insulin is the medically correct response. Modern insulin regimens are more sophisticated than a single daily injection. Zal insulin, long-acting formulations that provide a steady background level over 24 hours, mimics the normal low-level secretion that happens between meals and overnight. As of 2026, the FDA approved the first once-weekly basal insulin, reducing injection burden from 365 shots a year to 52. Rapid-acting prandial insulins cover the specific glucose load of each meal and are taken only when eating. The barrier isn't usually the effectiveness of insulin. It's psychological insulin resistance, fear of needles, fear of hypoglycemia, the feeling that needing insulin means the disease has won. Clinical data shows that when patients are shown the actual size of a modern insulin pen needle and given a supervised demonstration injection in the office, anxiety drops substantially and acceptance improves immediately. The needle is genuinely very small. The fear is larger than the object it's pointed at, technology that helps control diabetes. The continuous glucose monitor is arguably the single most impactful technology development in diabetes management of the past 2 decades. Not because it does anything to blood sugar directly, because information changes behavior, and continuous information changes it more. Current CGM devices, including the Dexcom G7, Freestyle Libre 3 Plus, and the Simplera Sync, provide real-time interstitial glucose readings every 5 minutes, require no fingerstick calibration, and communicate via Bluetooth with phones, smartwatches, and insulin delivery devices. Sensor wear is 10 to 14 days. The data stream shows not just current glucose, but trend direction and rate of change, whether your blood sugar is rising, falling, and how fast. This turns reactive management into predictive management. You see a rapid rise starting and you go for a walk. You see a pattern of 3 a.m. lows and your clinical team adjusts the overnight insulin dose. The intervention happens before the event. Insulin pumps take continuous delivery further. A subcutaneous catheter that replaces injections, delivering programmable basal rates throughout the day and rapid boluses for meals. The current generation of hybrid closed-loop systems, platforms like Control-IQ Plus and Omnipod 6, link CGM readings to pump delivery algorithms that automatically adjust insulin rates in real time based on predicted glucose values. The system makes dosing decisions without waiting for you to calculate anything. The term artificial pancreas is used informally for these closed-loop configurations. They don't replicate the full function of a pancreas, but for the narrow job of maintaining blood sugar within range, the most advanced current systems do it with a degree of precision that manual management rarely achieves. This technology is not yet accessible to everyone, and that's a genuine problem. But for those who do have access, it represents a categorical reduction in the cognitive and physical burden of daily management. Preventing diabetes complications. Every complication of diabetes shares a common origin story. Chronic hyperglycemia inside cells that can't regulate how much glucose they absorb, in the retinal cells of the eye, in the filtration cells of the kidney, in the Schwann cells that sheath peripheral nerves. These are tissues that absorb glucose regardless of insulin status. When blood sugar is chronically elevated, these cells are flooded with it. The excess glucose enters metabolic pathways that generate oxidative stress, cause abnormal protein cross-linking, and trigger inflammation. In the eye, this drives retinopathy. New blood vessels grow into the retina, fragile, leaking vessels that didn't exist before and weren't designed to exist. Left untreated, they scar the retina and cause blindness. Annual dilated eye exams exist specifically to catch this early, before symptoms appear, when treatment is still straightforward. In the kidney, the filtration membranes thicken, glomerular pressure rises, and protein starts leaking into urine. Nephropathy progresses slowly over years. Urine albumin to creatinine ratio, tested annually, is the earliest detectable signal. SGLT2 inhibitors and GLP-1 agonists both slow this progression with evidence from major clinical trials. In the peripheral nerves, particularly the long nerves running to the feet, chronic hyperglycemia causes damage that presents as numbness, tingling, or burning. The loss of protective sensation in the feet is particularly dangerous because injuries go unfelt, become infected, and in severe cases become untreatable. Annual foot exams with a monofilament test and tuning fork are the standard clinical screen. Heart disease risk is 2 to 4 times higher in people with diabetes. The same vascular damage driving these other complications is accelerating atherosclerosis throughout the body. Most complications develop over years, not suddenly. They can be delayed, slowed, and in some cases prevented, but only by the blood sugar control that starts before symptoms give you any reason to take it seriously. Can diabetes be reversed? For decades, the answer given to patients with type 2 diabetes was, this is a progressive disease. You'll manage it, but it will get worse. Medications will be added. That's the trajectory. The clinical research of the past 15 years has substantially revised that picture. Clinical remission from type 2 diabetes is now a recognized medical outcome, defined as an HbA1c below 6.5% sustained for at least 6 months after stopping all glucose-lowering medications. Not merely well-controlled, actually in the normal range without drugs maintained. The Diabetes Remission Clinical Trial, DIRECT, tested a program of total diet replacement at roughly 800 calories per day, followed by gradual food reintroduction and structured support. At 12 months, 46% of participants had achieved remission. Among those who lost 15 kilograms or more, 86% achieved it. These are not marginal effects. The mechanism is explained by the twin cycle hypothesis. Chronic positive energy balance drives ectopic fat into the liver, causing hepatic insulin resistance, which accelerates fat production and forces triglycerides into the pancreas. Ectopic pancreatic fat exposes insulin-producing beta cells to lipotoxicity, causing them to lose their glucose-responsive secretory function. Both cycles run in reverse with sufficient, sustained weight loss. Liver fat clears first, restoring fasting glucose. Pancreatic fat clears more slowly, and when it does, first-phase insulin secretion returns. The important nuances: remission isn't a cure. Weight regain re-exposes tissues to the same fat accumulation. The metabolic vulnerability doesn't disappear. And type 1 diabetes has no remission pathway in the same sense, because the immune destruction of beta cells is a different disease entirely. The answer to whether diabetes can be reversed isn't yes or no. For type 2, under the right conditions, it's yes for now if you maintain the conditions, building a personalized diabetes control plan. Nothing in this video is a universal prescription. Every mechanism described here, every dietary approach, medication class, exercise modality, monitoring technology, interacts with the specific biology of a specific person with a specific type of diabetes and a specific set of circumstances. This is why there is no standard diabetes plan. Building one that actually works requires assembling the relevant components and calibrating them to you. The 6 pillars are consistent. Nutrition comes first and should be individualized around metabolic response, not just population guidelines. CGM data is the most direct way to understand which foods drive your specific glucose spikes. Exercise should be both aerobic and resistance-based, timed strategically. Post-meal walks for acute glycemic control, resistance training for long-term metabolic capacity. Medication, where indicated, should target not just glucose, but cardiovascular and renal risk. The agent class matters as much as the agent. Monitoring should be continuous where possible, and the data should actually be used. Pattern recognition is the goal. Sleep hygiene is non-negotiable. 8 hours of metabolically restorative sleep is an active treatment, not a lifestyle preference. Stress management is clinical, not optional. The neuroendocrine system connects psychological state to blood glucose through direct hormonal pathways. And those pathways need to be addressed explicitly. The factors that matter most vary by individual, and they shift over time. Someone newly diagnosed with type 2 may achieve remission through nutrition and weight loss alone. Someone who has lived with type 1 for 30 years needs a more complex technical infrastructure. The complexity of the plan should match the complexity of the disease. The one thing that doesn't vary. The earlier the intervention, the better the outcome. The future of diabetes treatment, the trajectory of diabetes research, is the clearest argument for why managing the disease well now matters enormously. What becomes available in the next decade will be substantially better than what exists today, but only accessible to people. The FDA approved insulin EcoD under the brand name Weekly, the first once-weekly basal insulin for type 2 diabetes. Its half-life is approximately 196 hours, reducing the injection schedule from 365 daily doses to 52 weekly ones. This isn't a minor convenience improvement. Medication adherence is directly tied to the burden of administration, and once-weekly dosing represents a genuine reduction in the primary reason people skip doses. The more significant development is retatrutide, a triple hormone receptor agonist targeting GP, GLP-1, and glucagon receptors simultaneously. Phase 3 data from 2026 clinical trials, Transcend T2D1 and Triumph-1, demonstrated average HbA1c reductions of up to 2.0% and average weight loss of up to 28.3% over 80 weeks. A drug that treats the root causes of insulin resistance with that magnitude of effect changes what metabolic medicine looks like. Artificial pancreas technologies that would eliminate the need for carbohydrate counting and meal bolusing entirely. Dual hormone systems combining insulin with pramlintide to slow gastric emptying and mimic natural pancreatic co-secretion are in active clinical trials. What's coming is better glucose control with less cognitive burden, better organ protection, and better remission rates than currently exist. Diabetes management improves every year. The work you do now reduces the complications you'll face when these tools become available to you. If you found this useful, leave a thumbs up. And if you want more videos like it, hit subscribe and drop your ideas for the next one in the comments.